Greetings, my friends, and thank you very much to the organizer for asking me to give this talk about metronomic chemotherapy, which is very important to me. The way we understand how cancer work influence the way we understand how treatment works. So it's not a coincidence that metronomic chemotherapy was unveiled when we rediscovered the importance of the microenvironment in angiogenesis in cancer growth. And the two leading teams in the field of angiogenesis and cancer at the beginning of the century, so Timothy Folkman in Boston and Robert Covell in Toronto, published the same concept, is that using low dose frequent chemotherapy could have an anti-angiogenic effect. And its two goes hand in hand, coined the term metronomic dosing to this new therapeutic approach. If you give a closer look at the paper from Nicolas Andre and Timothy Brother, it shows that if you treat lung carcinoma cells grafted on mice, well, if you use the conventional schedule, you control the growth for a certain amount of time, and then the tumor gets resistant. Well, if you use the anti-angiogenic schedule, you got a sustained effect on the tumor. And if you treat mice grafted with someone that is resistant to the very same drug, well, the conventional schedule still can control for a limited period of time the growth of the cancer. But if you use the anti-angiogenic schedule, you still can control the tumor for a long period of time. So low-dose anti-angiogenic scheduling or metronomic chemotherapy has activity both in sensitive and resistant cell line. This is true for several anti-cancer agents such as cyclophosphamide and 5-FU et al., and true also for several types of disease such as lung cancer, breast cancer, leukemia. The treatment is well tolerated, and the key thing is that you change the target. You do not try to eradicate directly cancer cells, but you target the endothelium instead to get an anti-angiogenic effect. And if you look at the panels on the left side of the screen, if you measure the apoptotic rates in endothelial cells and tumor cells, when using a conventional schedule, you got an action of apoptosis in endothelial cells and tumor cells for 10 days, and then nothing much happened because you had to wait for your body to recover from the disease before treating again the tumors. Well, if you use the anti-angiogenic schedule, you can treat the tumor constantly and have a sustained induction of apoptosis both in endothelial cells and then on tumor cells. So these findings were confirmed in different models by different teams around the world, and that led to the definition of metronomic chemotherapy, which is the frequent administration of low-dose chemotherapy without long break. So if you give less but regularly, you get more effect. And this happens because you change the PK and then you change the PD, and therefore you change the target and you can overcome resistance. So, but this is a very conceptual definition, and it's not precise enough, and more specifically doesn't say what is a small dose, what is a frequent administration, or what is a long break. So at the end of the day, sometimes it's hard to say if a regimen is metronomic or not. An important thing that goes beyond the classical paradigm of targeting angiogenesis is that metronomic chemotherapy can also directly kill cancer cells or cancer stem cells. And for a given agent, if you give it metronomically, you can kill cancer cells with a mechanism of action that is different from the one that induces cell death if you use it in an MTD manner. And the type of cell death can also be different, and you are more likely to induce immunogenic cell death. And this is very important in a time where immunotherapies is gaining more and more importance. And metronomic chemotherapy itself is also important to strengthen the anti-cancer activity of the immune system. And depending on the agent that you use, not only you do not destroy the immune system because you give to high doses, but you can selectively deplete some cell from the immune system. For instance, if you use low-dose temozolomide or low-dose cyclophosphamide, you will deplete Tregs. If you use low-dose 5-FU or low-dose gemcitabine, you will deplete MDSC. And if you use low-dose vinblastine, you can help dendritic cell maturate. The team from David Waxman has been working intensively on what they call now MEDIC, for medium dose intermittent chemotherapy, which is to some extent between metronomic chemotherapy and MTD, and that schedule seems to be able to strengthen the effect on the immune system. And this has been confirmed recently by Robert Kerbal in a model of breast cancer, and they investigated this different schedule of cyclophosphamide, MTD, low-dose metronomic, or MEDIC. And in these models, the MEDIC was doing better in terms of tumor volume, mice survival, and if they checked at the content of the microenvironment in terms of immune infiltrate using multi-cell top, they were able to show that in the MEDIC group, there was an increase in intratumoral CD4, CD8 T cells. So we tried to explore that concept in a clinical trial for children and teenagers with refractory relapsing solid tumors, first in a phase 1 and then in the phase 2 randomized trial. In the phase 1 trial, there were one first arm in which we were trying to deplete MDSC by using capecitabine 1 week on, 1 week off, combined with nivolumab. A second arm with vinblastine cyclophosphamide to make dendritic cell mature and deplete Tregs. And then in arm C, with a multiple immune restoration using cyclophosphamide alternating with capecitabine combined with vinblastine and nivolumab. So at the end of the phase 1 part, the arm 3 was chosen as the metronomic arm for the randomized trial that will compare metronomic versus metronomic plus nivolumab. So metronomic chemotherapy combined with drug repositioning is called metronomics, and by acting at the same time on the tumor vasculature, on the immune system, and cancer cells or cancer stem cells can lead to control of cancer. There's been recently some important clinical trial using metronomic chemotherapy. The first one was published in Lancet Oncology a year and a half ago. Patients with high-risk abdominal sarcoma were proposed to receive a maintenance with weekly intravenous naloxone and daily oral cyclophosphamide. 360 patients were included in this randomized trial. And after the 6 months of maintenance, despite hematological toxicities, mostly grade 1 or grade 2, but sometimes grade 3, there was an important impact on survival with a 12% increase in overall survival. So adding a simple metronomic chemotherapy maintenance in patient can drastically increase survival without any fancy new drugs. And this is not such a surprise as early as 1963 was published the first randomized trial investigating a metronomic maintenance with perinatal in children in complete remission after injection for their leukemia. And that trial was successful at the time. Another recent interesting paper was published by the team of Samir Bakshi in New Delhi, and they investigated the role of metronomic chemotherapy in patients with progressive solid malignant tumors. Over 100 patients were recruited and randomized between best Loftia-Kell metronomic chemotherapy. Patients were proposed to receive the 4-drug metronomic protocol published initially by Mark Keelan with cyclophosphamide for 3 weeks alternating with etoposide with the addition of thalidomide and celecoxib. So the median PFS was 45 days and overall survival was 84 days, and they were similar in both arms and were not statistically different. But if you take off the bone sarcoma, because we know that these patient do not respond to metronomic chemotherapy, then you got a significant improvement in both overall survival and PFS. So this analysis was not initially planned, but I think it's very clinically relevant. And it also highlights that you cannot give the very same treatment to all patients because one side of metronomic protocol will not fit all. So the first thing that you have to take into account is the tumor type. There are some good disease for metronomic chemotherapy, such as rhabdomyosarcoma, acute leukemia, megaglioma, neuroblastoma, or TRT, ependymoma, and ideal that would be non-small cell lung cancer, breast cancer, ovarian cancer, colon cancer. Then you also have to take into account the setting upfront for the patient, like we do in the pre-phase for lymphoma. As we have seen, maintenance is clearly a good setting for metronomic chemotherapy. Refractory relapse disease, palliative care, of course, yes. And there is an emerging field that is the use of metronomic chemotherapy for low-income countries because it's easy to give, it's inexpensive, pretty non-toxic. And we performed recently a survey among pediatric oncologists working in low-income countries, and they agreed to say that metronomic should be used more often for their patients. And of course, when building your metronomic protocol, you can use chemotherapy, but also drug repurposing, but also targeted therapies or immunotherapies. And I guess a modern metronomic regimen should take into account clinical data, preclinical data from in vitro and in vivo experiments, then generates a metronomic protocol taking into account the duration of the treatment, dose and schedule, the choice of the drug. Then since most metronomic chemotherapy protocol have lots of agent, that's a lot of pills to swallow for the kids. So we have to pay attention to the mechanic of the drugs and use oral suspension as much as we can. Compliance is an issue, so we could send alerts, text message through cell phone. And then once the treatment is given, measure PK, measure biomarkers, put them in the computer to get a computational improvements of the schedules and dose for a given patient. So metronomic chemotherapy is mostly oral. It can be non-toxic. It's inexpensive. It has clinical activity demonstrated by phase 2 trial, but also phase 2 and phase 1. It's intrinsically targeted. You can impact on the angiogenesis, on the immune system, on the stroma, on cancer cells or cancer stem cells. It's important to use combination with relatively any agent that you can find and that you can build rationale for. And I think it's important to move to personalized therapy and personalized metronomic chemotherapy using PK, biomarkers, molecular biology, computational oncology, and also not forget all the social context. So I would like to thank you for your attention. Enjoy the meeting. You can get in touch with me to the following address. And if you're interested in metronomic for London countries, have a look at our website at metronomics.org. Thank you for attention. Enjoy the meeting. Stay safe.